What's the difference between ordinary worry and excessive worry? And how can healthcare professionals help people for whom anxiety has an impact on their everyday life? In this episode of the Clinical Update podcast, we'll discuss messages from a module on generalised anxiety disorder that's been really popular with our learners. I'm Pat Anderson, and today I'm joined by Rhiannon Ashman and Sangeeta Krishnan. Later in the episode, Sangeeta will be talking to urgent care specialist Dr Ivan Koay about some of the latest research, and we'll cover 3 key points from a module on chronic cough in children. But first, over to Rhiannon and Sangeeta for highlights on managing anxiety.
Thanks, Pat. Yes, so Sangeeta and I are talking through this module on generalised anxiety disorder, which has been written by Dr Alexandra Keys, who's a clinical psychologist at South London and Maudsley NHS Foundation Trust. As Pat, you said, this module's been incredibly popular with MIMS Learning's readers, so let's take a look at some of the content that it covers. We all know that worry is a normal part of life, but by the time patients are presenting to you, we can assume that their worry has become excessive or uncontrolled and is causing them distress. This is called the worry continuum, which we'll talk about later. Generalised anxiety disorder, or GAD, is more commonly reported in women than in men by a ratio of 2:1, typically in their late teens to late 20s. While its onset is often gradual, GAD can occur suddenly after stressful life events.
So, can you tell me a little bit more about the worry continuum?
Yeah, worry is experienced on a continuum, ranging from everyday worry on one end to uncontrollable and excessive worry, the likes of which people with GAD experience on the other end. Everyday worry about problems that exist in the here and now might prompt someone to look for solutions, but uncontrollable worry can be about problems that have not happened yet or might never happen and which you have no control over. So it's this excessive worry about hypothetical future events which is unhelpful.
Interesting. So, given that these feelings exist on a continuum, what are the criteria for a diagnosis of GAD?
We all know worry and stress are common experiences, but GAD might be indicated when this has become frequent, severe and uncontrollable, and is significantly interfering with someone's functioning. This learning module lists the DSM-5 criteria, which would need to be present for at least 6 months for a diagnosis of GAD. Signs and symptoms include a tendency towards perfectionism, difficulties with procrastination, difficulties with sleep, an exaggerated sense of responsibility, and a feeling of being on duty all the time. Interestingly, GAD can also present as a minor physical problem, according to the author.
So, in what scenario would you consider GAD in a patient who presents with physical symptoms?
Well, you might think about GAD in people who attend primary care frequently, who've got chronic physical health problems. Also, in those who don't have a physical health problem but are seeking reassurance about somatic symptoms or repeatedly worrying about a range of different issues. The author of this module notes that you should be particularly alert to this in older people and people from minority ethnic groups.
And what management options are available for someone with GAD?
NICE recommends a stepped care model for managing GAD. So, depending on the severity of the condition and which other options have been tried before, you might consider individual self-help, cognitive behavioural therapy, or drug treatment with an SSRI. You might also want to conduct a needs and risk assessment for the patient to determine what support they have available and the impact of their condition.
And why do you think this module has been so popular with our learners?
Yeah, it's an interesting question because it has been incredibly popular, this module. And my thoughts on it are that GAD is probably something that healthcare professionals are seeing a lot of. And also, they're probably seeing a lot of it in clinic where their anxiety is sort of tangential to the problem that they're presenting with. So I imagine that healthcare professionals are actually seeing a lot more of it than we might think. Thanks for talking through this module with me, Sangeeta. You can find the link to this module in the podcast notes or by searching on the MIMS Learning website.
Thank you very much, Rhiannon and Sangeeta. And we go now to our interview between Sangeeta and Dr Ivan Koay.
We are joined today by Dr Ivan Koay, who's an urgent care physician and medical lead at the King's College Hospital Urgent Treatment Centre, who's going to talk to us about key research findings from the field of urgent paediatric care. Pleased to have you with us, Dr. Koay.
Thank you so much for having me.
So, please, could you tell us a little bit about your clinical background and your current role?
I qualified from the University of Sheffield many moons ago. I found urgent care through a sort of meandering sort of process of initially doing surgery, then doing emergency medicine, and then finally doing my fellowship in urgent care in New Zealand, of all places. We returned back to London about a year ago now, and I'm the medical lead at the King's College Urgent Treatment Centre.
So, how do you find the difference between practicing in New Zealand and practicing in London?
Medicine is medicine, as someone told me a little while ago, and that holds true. I think the difference is that because in New Zealand, urgent care is actually a recognized specialty. So we have our urgent care centers are staffed by fully trained fellows like myself of the college in New Zealand. And so we deal with a slightly different acuity compared to what we have here. And there are a few other additional things that we deal with in New Zealand that we wouldn't deal with in our urgent treatment center here. But there is obviously scope for expansion, I feel, within the NHS if urgent care was to get recognition at some point.
Oh, that's interesting. Something I didn't know. You've been writing pediatric research briefings for us. How did you develop your interest in research?
Yeah, so it was an accidental finding in some ways. I actually had no inclination for research whatsoever when I first qualified for medicine. Was forced into it as part of what I was told at that time was a career progression move in surgery. So did a doctorate in surgical oncology at that point. And that's kind of where it's kind of sparked my interest in research. My doctorate was purely lab based, but I've always since then had this inkling about looking at the way we do things, the way we practice medicine, and how we can tweak things to actually make things better for our patients going forward. So whether there are improvements that we can make in the way that we manage patients, medications we use, treatments we use, and whether everything that we do is actually the best present evidence for our patients, or whether there are other things that we can look at in terms of changing the way that we do things presently for the future.
It's interesting to me to read research as well, but I find that there seems to be a gap between what's in research and what's implemented.
Yes, the problem I think is that people who are actually interested or doing research are doing it from a pure research perspective, and people who are doing clinical work are doing it from a clinical perspective. We need some people potentially that have that bridging sort of interest in both camps to um, so that what we do in terms of when we do research is not so purely hypothetical in nature, but has actually got some clinical application. I mean, the pharma team and the pharma sort of sector obviously does do that in some ways, but I think we do need that more in other fields as well, outside of just the pharma and pharmacology sector. Because I think as we will be discussing, there are things that we can actually do to improve the quality of life of our patients as they are going through diseases, injuries, and how we help them get themselves back into full health and fitness.
Yeah, so we need more people like you, in short, who sort of bridge that gap, right? Is there a standout recent research finding in pediatrics that has really changed your practice?
I thought about this, and a couple of things have come to mind. One is with regards to antibiotic stewardship, where there's now actually good evidence that a lot of the respiratory type illnesses that we treat actually don't need antibiotics. They are mostly self-limiting. Along those same lines, then there has been research done for pneumonias, for example, in children, where shorter courses are equivalent as the standard long courses, and there's no difference in terms of recovery periods. So that's one. From a stewardship point of view, then means that we reduce the resistance of incidents in the community, and we reduce any other sort of long-term side effect for patients, especially in children. And the second bit of research that stand out for me was the work in concussion. So concussion is one of these things that I've been interested in for about 10, 12 years. And the standard concussion advice that we give today has completely changed from what we did when I started 10 years ago, where there's now more a look at gradually increasing screen time, increasing activities rather than having that strict period of rest. There is evidence that moderation of screen time is actually useful. So especially in teenagers, where what they found was that if you give them strict advice to having no screen time at all for a period of say 2 weeks, then some of the children will actually be socially, because they're socially dependent on those screens to interconnect with other people, then that actually feeds into their other symptoms that and prolong their recovery period. And so there is that sort of inkling of moderation in some ways. I did present one of these findings to a boot camp some not so long ago.
You recently wrote a module on torus fractures of the wrist in children. So, what were the key messages in that?
I think the key message in that was that not all fractures need a cast. I think that's the standard. If there's one thing that you want to pick out from that, would be that. And especially in torus fractures, these are actually very stable fractures in configuration. They aren't as malleable as the green stick fractures, and definitely aren't unstable as the other fractures that are through and through. And so in torus fractures, splintage is as equivalent to a cast, and so less is more.
How should clinicians consider changing their practice around wrist fractures?
I think there is a move to actually, as I say, less is more. And so we can, with confidence, be reassured that a torus fracture does not need a cast. And so that helps in terms of our consultation process and the way that we spread the message to parents. Because as a parent, you can understand where they're coming from. Oh, my little Johnny or my little Bella has got a fracture. It's fractured. It's broken. You as a doctor or clinician are telling me my child has got broken bone. Why aren't you casting it? And so, therefore, then giving them the understanding that yes, they are fractures, but they behave differently from fractures that an adult would undergo, and therefore, treatment-wise, less is what is required, and there is no long-term impacts from a functionality point of view. I think that's the other message that a lot of parents are worried about, is that, oh, will that affect the way my child has, you know, be able to write or play sport or do anything else. And so long as we can and reassure them that from the understanding that we have that less is more, doesn't need a cast.
I think what you said is reassuring parents. That's the trickiest, most challenging part of it, isn't it?
Yeah, yeah, because most pediatric consultations are twofold, dealing with the child and with the parents as well.
Are there other game changing research studies that are currently underway that you're aware of?
This has just come across my radar, is again in the concussion space, where they're looking, but this is not pediatrics as such, but this is in adults, where they're looking at how to prevent depression in concussed patients who have had an injury, and looking at whether sertraline will help or not. So that's currently being recruited. It's called the Stop D research study. From a pediatric point of view, again looking at concussion work, there has been the new consensus SCAT-6 has come out in the last 12 months. And so there is more work there in terms of whether we then push the children to actually start doing activities, physical activities a little bit earlier, and then gradually get them back to full activity. At the moment, from a rugby perspective at least, the convention is still for a 28-day period stand down. And I'm not sure whether that is actually still going to be the case in the next 24, 36 months' time. There may be changes there.
And finally, I'd like to ask, would you like to talk about someone who's inspired you in this area?
From a research point of view, I think it's my uncle. My uncle is the professor of hematology and oncology in Indiana University, and he was one of the key members that found out that deficiency in folic acid is what caused neural tube defects in fetuses,
Oh, wow.
and has been actually pioneering a lot of work in that space, especially in subcontinent Asia and India, to actually get that, looking at ways to supplement either tea or flour to make sure that even the poorest of the poor who can't afford folic acid tablets will have children that don't have these defects. His curiosity about things is the thing that sort of inspires me. From an urgent care perspective, then clinically, I look up to, there's a gentleman called David Gollogley, who is a Scottish gentleman who migrated to New Zealand and was one of the founders of urgent care in New Zealand, and one of the pioneers that actually got the New Zealand College going and got recognition. And the simplicity and the tenacity of his sort of efforts is the thing that sort of inspires me.
Thank you so much for joining us today. I highly recommend visiting the MIMS Learning module on the tourist fractures of the wrist. And you can also check out other pediatrics content on the MIMS Learning Pediatrics specialty page.
Hi, I'm Emma Bauer, editor of the website GP Online and host of the Talking General Practice podcast. If you're interested in what's going on in primary care across the UK, do come and check out our podcast. Talking General Practice is out every Friday and includes discussions about the key issues and news stories affecting general practice, and interviews with GP leaders as well as inspiring GPs and others who are making a difference to patient care. Just search Talking General Practice wherever you get your podcasts to have a listen.
We're back for our 3 key points section, and we're going to talk about a module on management of chronic cough in children. This is by Dr Atul Gupta, who's a consultant in paediatric respiratory medicine at King's College Hospital, and it provides a concise guide to a structured approach to chronic cough in children. So what's our first point, Rhiannon?
So Dr. Gupta says that, unfortunately, parental reporting of cough does not correlate well with the frequency, duration, or intensity of the actual objective cough. He says the reported severity of coughing often relates to how much it affects parents or teachers. But what can be useful is the parent's description of whether the child's cough is wet or dry. This can help you to determine if there are secretions in the lower airway. So his advice is to take a good history and perform examinations, followed by targeted interventions if necessary.
Thanks, Rhiannon. And what's our second point?
Our second point is that possible serious causes of cough are many, including inhaled foreign bodies, but Dr. Gupta talks about some coughs having a particular signature. A barking or brassy cough could mean tracheomalacia. A paroxysmal cough with or without whoop could be pertussis. A chronic wet cough, especially in the morning, suggests suppurative lung disease. In older children, cough may be associated with psychological problems because it can be cortically modulated. Psychogenic cough typically disappears completely during sleep and may have an unusual honking character.
That's interesting. So it's important to listen out for characteristic sounds as they may help with diagnosis. So our third point is that Dr. Gupta says isolated chronic cough is a poor marker of asthma. Asthma shouldn't be considered based on cough alone without other typical features. Cough predominant or cough variant asthma does exist, but it's a rare diagnosis. Bronchial hyperresponsiveness or reversible airways obstruction are both key features of asthma, which can help to identify children with cough predominant asthma. So thanks, team, for going through these key points. As well as his module on chronic cough, Dr. Gupta's also written one on acute cough in children, so it's worth checking them both out. Thanks very much for joining us today, and please do tune in next time for a discussion of your own well-being as a healthcare professional with Dr. Farnaz Sharif. She'll give you some practical tips for maintaining your well-being in the moment and even in between patients. So we'll catch up with you then.